Okay, good afternoon everybody and welcome to the Health and Wellbeing Board meeting. Am I getting a little bit of feedback? I am getting feedback, I think it's from your... Okay. The meeting is being live streamed on YouTube, so you will have to use your microphones when speaking, so if you can just remember that, otherwise it won't be audible on the YouTube. So apologies for non-attendance. I'm still getting my voice coming back at me from just over there. We have apologies from Deborah Needham, Councillor Scott Edwards, Kate Williams, David Watts, and Samantha Fitzgerald is here in place of David Watts. Michael Jones, Naomi Eisenstadt, and we have Toby Sanders here in Naomi's place. Colin Smith, and we have Hannah Scanlon sitting in for Colin, and Sarah Hillier. Are there any other apologies that I've not? Yes, Joe. Pratima, didn't I just see her? Oh, I must be imagining things. So Pratima Datani, I'll add that one. Thank you very much. Notifications of requests from members of the public to address the meeting. We have had none. So we move on to agenda item 3, declarations of interest. Do any board members have any disclosable pecuniary interests or non-statutory disclosable interests in any of the items on today's agenda? No, that's great. Thank you very much. If we move on to the minutes from the previous meeting that was held on the 26th of September, you have all had those minutes and hopefully have had a chance to read through them. Are there any comments? Yes, thank you, David. Perfect. So if we can add David's name to the attendees list. Anything else on those minutes? Yes, Chris. Thank you. We'll make sure, Chris, that your name is also added to the list of attendees. Okay, it doesn't look as if anybody has any other things to say on that, so we will get those changes made and then I'll be able to sign those minutes off. So if we can then move on to the action log from that meeting. Hopefully you have seen some of this, but the first item was that, an amendment made to add Trevor Shipman to the attendance. That has been done, and it's nice to see you here again today, Trevor. Data on the uptake of sexual health testing has been supplied by Patsy Richards, along with a drill down of data on the area marked in red on the map used for teenage pregnancy. If you remember, we had a map and there was an area of red that was in the Wellingborough area, and it wasn't very clear to us which area that was. And from memory, it was the Brickhill and Queensway part of Wellingborough. With a view, and that was with a view to screening for what was and wasn't working within sexual health. The third thing was data to be provided by Sarah Bryden from Environmental Health in relation to air quality spikes. This will be available shortly before the next Northants Health and Wellbeing Board meeting. Does that mean before the one after this?
It should be before this one, but I haven't had it yet.
Okay, so that one is still to be dealt with. Okay, so we'll have to carry that one over, because although we thought that one was going to have been dealt with, it's not. And I think that's the same with our fourth item, which was access to GP appointments. Oh no, I think this one's actually been dealt with. There was a question around access to GP appointments being a barrier to cancer screening, and it was asked that be raised in the right forum. That's been raised by Sarah Bryden at the Cancer Screening Board, and we're awaiting a response from them on that. So that's partly dealt with, but we'll carry that over because we still need the response from the Cancer Screening Board. And then finally, I made a little bit of a plea at the end of the last meeting for presentations to come to the Health and Wellbeing Board from wider partners. And I'm pleased to say that the Office of Police, Fire and Crime Commissioner will be submitting a paper, and EMAS have said that they will be submitting a paper. So we will start to see some more information coming from others of our providers. So that, I think, is all of the agenda items that were to be followed up on. Is there any comments or responses to any of that? No? Good. So it looks like that's all covered off. Chair's introduction seems to be item number 6. I don't really have anything to say other than welcome to you all. It's great to see so many of you here today, and I'm looking forward to some really good items on the agenda and some good discussions around those items. There's some very important bits, particularly around that health and wellbeing strategy that we need very much your views and input on. So I'm going to go straight over to our agenda item number 7, and Chris Kenny is going to take us through the strategy draft of the health and wellbeing strategy as it is so far.
Thank you very much. Thank you very much, Councillor Harrison. Okay, yes, Chris Kenny, I'm one of the interim public health consultants with Northants, and at the last meeting of this board, I gave a presentation on the overall framework for the health and wellbeing strategy. So I'm not going to repeat any of that. The presentation that is in the pack includes a lot of what I talked about last time. In other words, making sure that the health and wellbeing strategy is based on an assessment of health need, is taking into account all the different strategic contexts which there are locally across the whole of Northamptonshire, and taking into account stakeholder and other professional views locally. So we had that discussion last time, Chair, so I wasn't going to go on that again. I would like to go straight to what is essentially page 47 in the pack, and I'll go from there, because at the end of the meeting last time, Chair, we talked about having 5 priority areas for the health and wellbeing strategy: children and young people, mental health and wellbeing, keeping active, economic prosperity, and tobacco. And I don't think there was much particular dispute about those being 5 areas that we could all gather around to actually promote the health and wellbeing of people in Northants. However, what does that mean in practice, and what is the role of this particular board? So that's what I want to focus on. What I did was I spoke to a number of people, not everybody around this table, but a large number of people, and asked for their own views about how useful it would be for us to develop, an action plan type of approach to each of the priority areas. That didn't go down well because there's already a lot of action going on locally, and one of the issues is we are developing a health and wellbeing strategy at a time when there's a lot of work going on. So after some large number of discussions, I came to a conclusion that it was about leadership, it's about coordination, it's about a focus on stakeholders, ensuring their views are taken into account, reviewing progress, and accountability for action at local level. And I'm just going to say a few more words about each of those in the context of the Health and Wellbeing Board. So in terms of leadership, one of the issues is there's already a lot going on. Just taking children and young people, just as one example, huge amounts of work going on, whether it be within the NHS, whether it be within local government, whether it be in the voluntary sector. And what a lot of people have said to me is, can we just sort of better coordinate what is going on? And so the next slide, slide 49, talks about the Health and Wellbeing Board showing leadership in this area, not telling people what to do, but ensuring that it is brought together. And the concept of having a Health and Wellbeing Board sponsor, so somebody around this table today putting their hands up and saying, yes, I'll be the sponsor for this particular area. In addition, we would have a sort of topic leader, somebody at sort of director or assistant director type level, who would actually lead the process of putting together what the plan needs to be in that particular area. And also, Jane, as the DPH, has already said that we would ensure that there would be public health support from the Public Health Department in Northants to ensure that a lot of the work is done behind the scenes to get everything action orientated. The next slide talks about coordination as a function of this board. So that's ensuring that all aspects of the priority area are coordinated. You know, aligning local and national initiatives. I mean, to just take, for example, the Keeping Active one. I mean, I have come across a huge number of both local and national initiatives about ensuring people stay active. And in fact, the briefing that we had with yourself the other day, there was a lot of work going on. But some of that needs to be brought together. Avoiding duplication. One of the I think the cardinal sins of anybody working in the public sector is to, is to duplicate unnecessarily. It wastes resource and it becomes inefficient. So avoiding duplication. An inexorable focus on inequalities. I think that goes without saying. I think that is a fundamental principle behind all the public health work that we do. We must focus on health inequalities. And ensuring that there is a strategic fit with other priority areas. So that is the sort of coordinating role I see for this board. What about the stakeholder focus? That's the next slide. Well, unless we get ownership by all the different stakeholder groups, the health and wellbeing strategy won't function properly. It needs to be owned. Everybody around this table needs to own and say, yes, I'm right behind this, whether it be statutory organisations, NHS bodies, local government, or community groups in the charitable sector. Everybody needs to own it. And there need to be contributions from all health and wellbeing board partners. Your comment about getting other presentations from other partners is really, really important in that respect. Publicity. So sometimes the work that we do is in the media. I think it needs to be much more in the media. And another good example of that is the tobacco agenda, that we're getting more resource from that, from central government over the next few months. And we need to really sort of pump up what exactly is it we're doing about that to the local, using the media. So stakeholder focus. Review. I think this is going to be really important. And my suggestion is that we review, at each meeting, don't take over the whole meeting, but at least have a focus on one of the priority areas. So, for example, at the next meeting, we haven't decided exactly which one it would be, but it could be tobacco, for example, because we'll be in a position to sort of make recommendations, I think, Jane, about how to spend some of the new money. So each meeting will have a focus on one of the 5 priority areas, ensure a comprehensive assessment for that area, ensure that we are addressing health inequalities, and agree what are, I've used the phrase there, 2 to 3 year plan of action. What exactly are we going to be doing to ensure that priority area comes to fruition over the next couple of years? And the next slide is accountability. Review progress. If this board is setting the overall direction and setting the overall coordination, we do need to review it at each meeting. Feedback to stakeholders, ensure success is celebrated, and if there is lack of progress, then we need to be able to support that in the best way we can. And the last point there, ensure any finance is used efficiently and effectively. We mustn't duplicate. I think there are at the moment in the system inadvertently areas where we do fund things inadvertently twice, I think. That's my observation over the last few months. And the best thing that we can do is to avoid any of that duplication. So in summary, Chair, this slide deck has tried to describe what the health and wellbeing strategy is, a range of contextual issues, the need for a robust engagement process with key partners, and I've made suggestions about how this Health and Wellbeing Board could operate in relation to those 5 priority areas. Thank you.
Thank you, Chris. That was really helpful, and I think what Chris has described is a really dynamic way of us as a Health and Wellbeing Board making sure that we're all, as partners, working together and contributing to achieving the aims and work on the priorities set out by the Health and Wellbeing Strategy. It's definitely different to producing a document that says we're going to do this, 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 this and this, and then dusting it off once a year to see if we've actually made any progress on those things. Personally, I feel that this is a much more engaging way of going about it. It feels to me like we'll sit round this table or these tables and genuinely have to commit and discuss and work out who's doing what and why and what's working and what isn't, and keep pushing each other towards those aims. And that feels to me exactly what a Health and Wellbeing Board is actually all about. So Chris has introduced it. I've thrown my penny's worth in. But what we really want to know is what you as a health and wellbeing board think about that sort of structure and design and what it is we're hoping to achieve and get agreement on. So I see that Jane's got a hand off and then David.
Thank you. Thanks, Chair. Thanks, Chris. So just to think about where we're going in the next phase with this. So what we'd be looking for and what we need really for people to think about as an action from today's meeting is to think about who would be willing to be a sponsor for one of these particular areas. So I, for example, will stand forward if needed to maybe be a sponsor for one of these areas. What that will mean for me as an individual is I'll get support from the public health teams. What we don't want to do is expect very busy people to be doing more work. You'll have support in terms of project management and having overview and oversight of that area of work. But we do need somebody who's going to be a sponsor working with a lead who might be a topic expert in that area. The role of sponsorship really is to keep the profile of that area going with the Health Wellbeing Board and also with all of your partners around the table as well. We'd also want to put in place quite, I'm a very process-orientated person, so lots of process around that so that we really can show progress against those action plans. But I just wanted to reiterate something that Chris said. The most important thing we've heard from all of our partners is lots of this work is going on already. It may not be consistent across the patch. We may not know about it. But also what we don't have is a single point of oversight for all of that work. So it's taking a fairly simple one in terms of, we've called it tobacco, but I think we'll probably call it smoking and vaping actually, is that loads of work is going on around that. We've got that in the NHS, we've got it in the local authority, our partners in trading standards are doing a huge amount of work. What we need is oversight of where that work is aiming to go, where the barriers are. So if we are struggling, for example, with women attending delivery, they're smoking, do we need to do something different as a system? That's the purpose of this strategy, is to unblock the blockers and work together as consistently and supportively as possible. So I just wanted to give that remark, if that's okay, Chair.
Yeah, thanks, Jane. I think it was really useful to go into a bit more detail of what that sort of sponsorship role, an expert role might be, because what we don't want to do is terrify somebody that we're going to give them another full-time job on top of the full-time job they've already got. So it's absolutely, it's not, you know, the support would be there, and as Jane says, the process behind that would be there. David, I think you wanted to come in.
Thanks, Helen. Helpful to have the context. I'd be really interested in proposing an interest in the sponsorship role for a few reasons. One, I live out near Oundle, so I know this place, or I'm getting to know it. And the second is I'm really interested in the anchor angle with a lot of this. So in terms of us as an organisation working with partners in the ICB, kind of what is our, you know, employment was mentioned there as kind of one of the standout kind of trend areas. So there's a real opportunity there. So I think that would be quite interesting to explore. But I'll leave members to kind of explore that, and maybe you can confirm next steps. Just on the tobacco, it would be good. I think tobacco, it's important to keep it there because the illicit tobacco trade is kind of pretty strong, and that's a driver of smoking and then vaping, of course, so that would be helpful. And the only thing, just from a kind of perspective, the one thing that seems to be missing is the word COVID. And I don't think we can get away from it, really, because it's kind of setting the scene for kind of health trends. You know, if we take some waiting lists, they're stretching into 5 years from now for some disease groups or need groups. So I do feel like there's an angle around COVID in terms of that lag in morbidity and what the corresponding need is going to be as it pops into the system downstream, and then how we make relative priorities against that need, both financially and in terms of service configuration. So that would just be an observation that I think is...
Yeah, thanks, David. That's really helpful. Really helpful that you've offered to put yourself forward as a sponsor. That's a really great start. So no pressure on the rest of you, but well done, David. And your comments about COVID are really important. And I think if you look at all of those priorities, there will be an element of COVID-related issues within each and every one of those. So I guess that, you know, it could be an important sort of sub priority that works its way through all of those. I mean, even tobacco, I would suggest, because I think people's habits and have changed during that period. So I think that's a really important point. Toby, if you'd like to say something.
Thank you. So, building on other people's comments, I think the approach of this is complex, isn't it? We've got so many different strands of work running, some of it in the north, some of it across the whole of the county, some of it broader than that, that trying to kind of set everything down in another document or another plan or another set of plans, frankly, I don't think is what we need. So I think I really endorse the approach of being a bit more iterative with it. I think, Chris, you used an interesting word a few times there, which was, what's the role of this room? What's the role of this board in relation to this set of stuff? And in my quite simple brain, there's kind of four questions, I suppose, I'd have of each of those 5 areas, because I think they're good, sensible areas. Firstly, what's the problem or the issue that we're trying to solve or improve in relation to each of those for this place, for North? Secondly, what's already underway? And there's a whole raft of stuff underway through different kind of routes. Thirdly, given those two things, what, if anything, are the gaps for this population that we don't think are being adequately addressed at the moment, where we don't think there are sufficient programs of work around them? And in relation to those, what then, and I think this is the USP of this room, what then is or could be the contribution of partners around this table? And I say that intentionally because this is quite an unusual combination of different agencies. I'm looking particularly to that sort of side of the room, who I know probably sit through some of these conversations and think this is all very fascinating and very kind of health and wellbeing orientated, but how do we play into some of this? And I think for me it's about trying to bring it practically back to what's the contribution that the different agencies in this room can bring to those things. So I think they're logical 5 areas. I think that kind of approach is sound. For me, if I was just sort of pointing to one of those 5 that I'm probably most anxious about, if I'm just being open in terms of my knowledge of where we are as a county and as North, it's the children and young people strand. Because if I look at something like mental health and wellbeing, looking particularly at David and from my world in the health, NHFT and the mental health collaborative we've got, there's a really clear programme of work, there's clear leadership, there's clear resourcing. That's not to say it's all in hand, but I can see a very clear way forwards there. The CYP strand feels to me that it's still got so many different layers to that, the relationship with the Children's Trust, the role of some of our other forums, that I'd welcome when it comes to the scheduling of bringing these through, quite an early conversation on that one, because I think it's one that we could help from here to move forwards. Thanks, Chair.
Thank you, Toby. Jane.
Thank you, Toby. And that's almost exactly the same questions that we were hoping to put at the in-depth sessions that we're going to have. So what we will do is bring some of the, let's take children and people will come back to you, because you're absolutely right, it is very complex, so we'll come back to that one. But let's take smoking again as the example. We will come with, this is what is going on, because that we can find that information, we can give the data, we can do all of that. But those questions about what are we not doing, where are the gaps, where are they, and what is the role of this group in taking that forward is exactly what those conversations will be. And then what we'll do with that is build an iterative action plan. So what we didn't want to do is set out with a high-level strategy and then look to put action plans behind that. We want to do that at the same time. So the next time we come to Health Wellbeing Board, we can say, this was the discussion, this is what we think the action plan will look like based on that discussion, and that's how we'll move forward on each area. Children and young people is going to be a big discussion, absolutely, because there's lots of players in that particular area, and we'd need to be really clear on what aspect of children and young people we really want to focus on as a board. So that would come into that discussion as well, because we'd need to be quite specific there. Some of these are easier than others in terms of that specificity. But no, those 4 questions that you raise are exactly what we've been talking about as part of that discussion. Thank you.
Yeah, thanks, Jane. Ali.
I think it's bringing the Live Your Best Life strategy into the room, going back to the purpose of this board. So we have that strategy. It focuses on the wider determinants of health and socioeconomic elements. That's the opportunity. We've got an outcomes framework. We've got ambitions. It brings it back here. What we need to do is hook then what were the priorities and the work around that. And I think there is a lot of work, but it's not always focused on the socioeconomic elements and the wider determinants. So we've got an opportunity to do that if we're going to make the outcomes. And I know we know that, but I think it goes back to it with the ask of both health and wellbeing boards from ICP.
And I think, Ali, it's about what do we add? You know, as a group of people sitting around these tables, what do we add to what's already being done? What do we add to the equation? how do we shine a focus on something that perhaps isn't being focused on as diligently as we would like. So it's really important for us to come away from these meetings, think, we did something important today. We worked something out. We worked out a direction of travel that had been missing, or, we're all very, very busy people. We've got hectic schedules. So I want people to walk away from these meetings thinking that they've done something useful. And I think that's why I really like this iterative process, because I think it does mean that we're active partners in this. I mean, we're already active partners, but we're looking at that added extra. I think you're right to shine the focus back on the Live Your Best Life strategy, because that is where, if we're honest, things tend to fall down. And so, we need to keep a laser-like focus on those issues. So thank you. Rochelle.
Thank you. It was just to pick up in terms of the priorities, and it kind of links really what Toby and Jane were saying around the children and young people, because it is such a broad area and quite complex. And looking at the priorities, other than the children and young people, they're more thematic in terms of how they're based, whereas children and young people is very demographic based. So I think it would be good to explore, maybe in those more deeper dive conversations, is that priority children and young people, or actually should we be targeting it more in a theme, which will then kind of start to put a microscope on certain aspects within the children and young people space? Because when I look at that, I think, gosh, how on earth would we, because it's so cross-cutting in terms of mental health, keeping active, economic prosperity in terms of, moving into adulthood, that to me kind of maybe just needs a little bit more discussion and stuff around that. Thanks.
Yeah, I think that's absolutely fair. And if we make things too broad, I don't think we would be able to judge whether we've made any impacts at at any of the staging posts. So we do need to know what it is we're drilling down to, and what we think as a board we're going to be able to push along and make a difference to. So I think that's absolutely right. Chris, I think you wanted to come in.
No, just to say, Rochelle's absolutely right. The exact details of what we will be doing are not at all sorted yet, and that's the whole point of having a sort of almost sort of a slow process of ensuring that we get something that's usable and credible. If we rush into something, it won't be. And the other thing, just to say, Chair, that there's no expectation that we start allocating board sponsor roles at today's meeting. That's not going to happen. But behind the scenes, we will start to do that. But it's really the sort of principles behind all this that's really, really important to get people's views on today. Thank you.
Yeah, absolutely, Chris. Yes, sorry, go for it.
That's okay. I didn't have a nameplate, but I'm Steve O'Brien from the University of Northampton. I'm just looking at page 55, and page 55 sets out the project timeline and next steps. But what doesn't seem to be there for me are the next steps. I mean, explicitly what happens next, because I think, if I'm reading this correctly, this takes us through what's happened up to this juncture. And then you publish the strategy. But then the real work begins, doesn't it, in terms of what people have been alluding to, in a sense. Not that you haven't been doing any work. I know you have been doing work because you interviewed me. So I think, for me, it would be really useful just to have perhaps what's going to be happening early 2024 in terms of those deep dive, the clarification, how you get your head around the whole CYP agenda, etc., etc. That would be really useful.
Yeah, thanks, Steve. I did know your name. It just wouldn't hop into my brain quite quickly enough. Yes, so would you like to respond?
Absolutely, Steve. Yes. No, the work done so far has been great, but the work to be planned in 2024 is slightly different. And you're quite right. This timeline does need to be expanded on the right-hand side for the reasons that you've just said. What I wanted to do is to make sure everybody was comfortable with this today before coming up with a sort of, this is the plan for next year. Really. Yeah.
Toby.
Sorry, thank you. Just another thought on the approach, because I think what is suggested therefore is that that work kind of takes place and then we come back here and look at a topic or one of those 5 areas on a rotational kind of basis. I think Just a thought on how we do that. It might be worth thinking about whether we hook, I know this is already quite a large room as it is, but looking at some of those areas, there are folk across our system and across the north who their organisations or individuals will already be leaders in this kind of space. They might not necessarily be sat around this table all of the time. And so I'm mindful, particularly if I look at something like the Keeping Active strand, I know in other neighbouring patches where we've done a deep dive recently into that, there was a number of partner organisations that kind of joined us, but on that particular occasion rather than as an always thing. I think it might just lead to a kind of richer debate and discussion here if we're then having that conversation on a kind of as-is basis with that, and then they don't always join us each time round.
Yeah, thanks, Toby. Jane wants to come in and...
I think in how it would work, Toby, is that the public health resource would make sure that the right people were around that discussion. So we would have dedicated resource in person time. So, for example, if there was what we've been talking about is there are some physical activity forums, for example, where lots of people come together, that public health resource would help us go to those groups and say, you know, what do you think, and do that engagement. So we would never expect the sponsor, for example, to do that, but they would have dedicated resource to do that for them. And maybe the sponsor's role is more about, well, actually, there's this amazing group who meet at KGH, or this is amazing, and that person then brings all that together. Because really what we haven't got for some of these areas is even a very clear mapping of what is happening and where it's discussed and with whom. So that would be that person's role. And it may be that an existing group, one of the proposals, we want this to be very much from the Health and Wellbeing Board, it may be that there's an existing group around physical activity, for example, who say, well, actually, we feel we are the home for that. We're the home for that piece of work. And that person might say, well, I'll be the sponsor then, or somebody else is the sponsor, but there'll be work between those people with that public health resource in the middle to do the doing, so to speak. Because there is so many fantastic existing assets that we've realised when we've looked into this, that we wouldn't want to miss any of that. You know, we are essentially here representing so many organisations and so much work. So that would be the way we'd take it forward.
Thank you, Jane. Sam.
Thank you. So really interesting. Thank you, Chris. The more I've listened to those rich discussions, I just kind of was thinking, actually, is this a board development session with wider attendance? So some of the other work that we've worked through, we've used the organisations that are in the room and put a task into the room to work through those, but in a really collaborative way. So back to Toby's point around, actually there will be a lot of people that we know or are connected to, or work streams. And even when we were talking about the children and young persons work stream, it's a real shame that David's not here, because obviously he's recently taken over as chair, and that group's kind of getting reinvigorated. But I did think, actually, this is so important and it's so vast that would it be worth having some form of board development session and making sure that we get a good period of time to get the great and the good from across the north to come in and really start to shape and frame some of that, in order to kind of move through, get the sponsors identified and create that kind of buzz, with this being the forum that the outputs of that then come back to. Just a thought.
I think, you know, I can't see any reason why we can't do that. I think the richer our discussions are, and you know, the more input there is, the more buy-in there's going to be from organisations, and you know, I think we will get that richer product at the end of it all. So yeah, absolutely, I think that's a really good idea. I think Chris looks like you wants to come back in.
No, I totally agree, Sam. I think the ability to have a rich discussion is much better in a development session. So we'll have to just talk through with Councillor Harrison about how that happens, because of course this is a statutory committee of the local authority, and the health and wellbeing strategy is a statutory requirement of that. So we just have to think through the sort of governance stages of how the discussion happens versus how decisions are taken. And we haven't come up with any conclusions yet, but what you've just suggested is very welcome. Yes, thank you.
Thanks. We've got David and then Rochelle.
I agree. I mean, I think that would be helpful to kind of, I mean, as much unpacking as can be done would be helpful. I mean, I guess one of the flaws with JSNAs in my previous experience is they don't get used, so they have to have a purpose. So in that sense, they need to be timely, so they need to land in a kind of a planning cycle. And there needs to be an objective to the evidence that is collected in terms of what is the need, and then what are the gaps, and what are we going to do about the gaps. And that's the big question. I think the identification of what they are and what's needed and so on, I think that's a path well trodden. I mean, they've been around for years. I think it's then what is the formula by which we're going to approach and the principles by which we're going to approach the gaps that are identified. That's really the bit I think that we need to move to, I think, fairly quickly.
Thank you, Rochelle.
Thanks. And it was just picking up on what Sam was saying, because I agree, but also reflecting that obviously we know there's loads of stuff already going on. So in the danger of kind of creating, more stuff, it's, I think, a good opportunity to seek where there's already activity that we can, link into as a health and wellbeing board or support and drive forward. So in the children and young people space, for example, Family Hubs programme is really gathering momentum. We have a governance structure around it. We have a partnership board, which Councillor Harrison is the vice chair on. So there's a real link there. And the family, talking about children and young people, Family Hubs is 0 to 19 up to 25%. So in terms of your boundary and function line, that's the vehicle to really deliver transformational and significant system change within the children and young people space. So it would be interesting to understand how, as a health and wellbeing board, those two can, collaborate and work together for true system change.
Yeah, thanks. Jane.
Thanks for that, Rochelle. I think that's a really important point. I mean, family hubs have been at the front of my mind in relation to children and young people, because it is an opportunity to wrap services around individuals in a way that we know people want, but in a way that sometimes can be challenging for organisations when people are commissioned and services are provided in a different way, etc. And I think that is a really good contender, I think, for area of focus for this particular piece of work, because the family hubs are just starting, aren't they, really? We've got one open now, I think, the Wellingborough one. But that, as it goes forward, is going to need support from people around this table in terms of how services are delivered around families and young people, and also how we sustain that going forward. So I think that's a really good suggestion as something we should put in that kind of pot, if you like, for consideration.
Fantastic. Well, I think from that discussion, it does sound as if we have a general consensus that this is the right approach to be taking, which is really good, because obviously we can start to develop that out now and take that forward and continue with the development of this strategy. So what we're being asked to do is to note the contents of the draft strategy, which we've absolutely done, and the progress that's made with regards to finalising the strategy. I think we should add to that we there's consensus from this board around the direction of travel, how we want that to work, because I think that's quite important. We don't want to get to January and then find that people are saying they don't want it to work this way, but all the discussion has sounded very supportive. So if we could just perhaps see a show of hands to say they support the direction of travel that this health and wellbeing strategy is taking. Perfect. That's really good. Thank you very much. And thank you, Chris, for all your hard work and for presenting that. So if we can move on to agenda item 8, we have the annual review of the suicide prevention strategy. And we have, I believe, Andil Chigbo and Arti Chigbo here to present the strategy. Is that right? Do we have?
Hello. Hi.
Oh, there you are. Sorry, I'm looking around.
It's all right.
Is it right that there's 2 of you?
Well, it was meant to be, but I'm representing the team today.
Okay.
She couldn't be here. I'm Andile Chigbo. I'm public health practitioner for mental health and suicide prevention in Northants. I'm just representing the suicide prevention team, which is a county-wide team. We have a practitioner in the west and an officer who works across the 2, as well as a consultant oversight who sort of looks over the whole thing. We just wanted to bring the first annual review of the Northamptonshire Suicide Prevention Strategy and Action Plan to you today. So the strategy was actually developed last year and launched last year. So we're just doing the first sort of annual review of the strategy and have gone through sort of a robust consultation period with different groups, and I've brought it here today. Just looking at some of the key achievements from the last year, there was a deep dive of the local data completed, We have our local suicide audit, which sort of has identified some of the high-risk groups in our local area. Those include substance and alcohol misuse, self-harm and previous suicide attempts, adverse events in childhood, relationship breakdown, mental health conditions like pre-existing ones, physical conditions, debt and finance problems as well. And just looking at some of the key achievements, which were really driven by Hannah Palmer, which is our other practitioner. I started 6 months ago, so I'm just picking this up really. We started a training framework across the county, a mental health and suicide prevention training framework, and have actually recently employed a training lead who's sort of taken the lead on the training framework across the county. This is to train a different range of groups from different levels, like a tiered system. So depending on what kind of tier you need, you sort of take on that kind of training. There's also been a pilot for call handlers, which was piloted in West Northants, but we're looking to expand that across the county as well, just to support call handlers as to how to manage telephone calls when somebody calls in crisis, where to signpost them, how to communicate, etc. There's also been a successful sign-up to the National Mental Health Suicide Prevention Concordat last year, which is an initiative by OHID, so it's a national initiative, and Northamptonshire was successful in signing up to that last year. So the actions are being delivered as part of the work areas for the suicide prevention team as well as storm training, which is for hospital staff, so it's another part of the training framework. We'll also have a real-time surveillance system, working quite closely with the coroner's office, looking at the cases in Northamptonshire. And as a team, we'll sort of go into the coroner's office probably like 3 times a year. I think that's what they did last year, 3 times a year. So we're going again in January to sort of have a deep dive into the cases that have come up until that time. So we know what we're doing with those cases. And then we currently have a piece of work going on around self-harm, just looking at self-harm admissions in Northamptonshire, which actually came up as higher than the national average. So we're just looking at the why at the minute, and then we'll continue that work once we have a good analysis of the data. There's also been a support package for schools after the tragic death of a young child in Manor School. So we've developed a support package for schools just to help them on how to manage suicide, so a post-vention package for schools. I think that's all in terms of our current achievements. So in terms of the consultation period, it's sort of been from September until now. We've taken the strategy and action points to the Suicide Prevention Steering Group, Mental Health and Learning Disability Autism Pillar, Children and Young People's Partnerships, as well as having lived experience input. So the plan from now is sort of to add some actions from those groups and some contributions that they've had, as well as updating the strategy to be in line with the national strategy, which came out in September this year, making sure that we keep in line with what's going on nationally. So the national strategy is a 5-year strategy, with most of the actions being delivered within the first 2.5 years. There was a paper sent out with our action plan. It's quite hefty, quite a long action plan, but it sort of breaks it down into the different priorities, which are in line with the national priorities, and has where each action is, who's leading on the actions, and what's happening around the actions, and also has all the completed actions at the bottom of the document. So I'll let you guys have a read of that. I think the one that I'll just highlight is priority 8, which is our additional points that have come up from this consultation period. If I can get to it, sorry. Yeah, so priority 8 looks around making sure that we sort of incorporate everything that has come up this year, completing the mapping of mental health services across the county, and especially bereavement services. We sort of highlighted that our bereavement services, I think one was decommissioned this year, so just making sure that we have like the suicide bereavement services in place in the county, developing an online harms package in line with the online harms bill that was passed in government, and that will be alongside a self-harm package as well for school and educational establishments, reviewing the call handlers package in line with what's going on in the county with our police officers and how they're sort of no longer attending mental health crises as they used to, so making sure that we're in line with the documents that have come from them as well. And also looking at safeguarding and looking at children and young people safeguarding as well as adult safeguarding, and making sure that we have a safeguarding process in place. Yes, I think that's all in terms of the... Also looking at domestic abuse, which is one of the areas that came up in our local audit. Yeah. I think in terms of what we've added so far to the action plan, those are the points. So it was just to sort of bring it to you so you can have a look at the action plan, have a look at the document, and just see if you have any comments on that. Thank you.
Thanks, Andale. You know, having been part of the group at the beginning when the strategy was first developed, and thinking, wow, this is a huge piece of work. There are so many parts to it. It's really good to see so much progress against so many of those actions that have been planned, and also to see that this is a plan and a strategy that will change in time, given further input from people and further development. So it's really good to see that it's changing and developing as it needs to. I know Jane wants to come in and say something.
As always, thank you. Thank you, and thank you, Andale. And the couple of things, so there's a huge amount of work here that's gone on, and there's just two points I'd like to raise. When you look through the list of actions completed, there's some really amazing resources there. So you've got the training offer, the bereavement support, the self-harm service mapping, to name but a few. I'm just wondering, how is that being shared with the organisations of the Health and Wellbeing Board so that people have access to all of the products, if you like, or the work that's gone on by this group? So I just wanted to ask you that one. And the other one is self-harm. I have real concerns about the levels of self-harm. We are really quite significantly higher than average, and when we even break that down to about small areas, we have some areas with really high rates. And I just wonder whether, jointly with NHFT, whether there's a piece of work we should be doing to really understand that in more depth. What is driving this, and what else could be done? Because the rates, you wouldn't expect them, I don't think, looking at our wider demographics and our wider population level outcomes, for them to be quite as they are. So I'm wondering if we need to really focus in on that as well.
Andale.
In terms of sharing the documents, I think the approach that was taken previously is sharing, in terms of like the school support package, it was shared with the schools. I'm not sure if it came via the Health and Wellbeing Board as well, but I believe it went through a process of being signed off, but not exactly coming to the Wellbeing Board to say this is what's going on. I think going forward it would be very useful for us to bring them here prior to them, to them being disseminated.
Make a suggestion, Andale, and this is slightly difficult because we do have some issues in the council hosting some things online, but it would be great, I think, somewhere to have resources that people can download and look at. Yeah. So if we could look at maybe picking that up as part of the action plan, is that we do have accessible resources for all communities, but also people, members of the board.
Yeah, perfect. Thank you, Jane. I'll definitely look into that. And with the self-harm data, it's been a difficult task for our data analysts to actually even get their hands on the data. But finally, we have the data and are working quite closely with NGH and KGH just to see how it was sort of reported, to see the why, per se, behind why Northamptonshire became so much higher than the national average, just so we can understand the why first. So our data analysts currently have the data and they're looking into that. So I think once we have analysed the data and have all the information from both our acute trusts, then we'll be able to move forward from there.
Thanks, Andale. We've got quite a few people who've got questions for you or comments, so we'll take them in turn. So Trevor first.
Well, it starts off with the latter point, and that was about the self-harm, and it was about that sharing data. So if there is any issues, please talk to us, because for us it's an issue for the public and the population. But if we can try and be part of the tool to support you in sort of delivering some sort of support around that. Second one was actually around this whole bank of information and how we get access to it. And you mentioned, for example, training on sort of switchboard operators. The number of times our switchboard operators at the acute trusts get calls that they need to be aware of what the background is. We need to make sure they've got that training as well. My final point is actually just on some of the mental health bits, and going back to your 8.1 slide there. I think some of this we need to be looking at when you say about mapping access and when people can get access, we need to be mapping it on a 24/7 basis, because so often people can get access to a service, but they can get it 9 to 5, or they might be able to get it slightly more than that. And so it's knowing where we've got 24/7 cover, because at the end of the day, people do end up doing things because they can't access a service on a bank holiday Monday or whatever. So actually having that clarity will greatly help what we're doing. But no, huge amount of work here. Thank you.
Yeah, thank you, Trevor. Really great points. I'll let everybody else, and you can come back after if that's okay with you. Toby next.
Yeah, thank you. A comment and then a question. The comment, and this is clearly such a hugely important area of work. I fear, looking at where we are from an economic point of view nationally, or where we are in terms of winter, where we are in terms of coming back after New Year and Christmas, whilst there's kind of one discourse nationally that kind of seems to think things have eased and we've moved for so many of our families and population households, actually things are harder now than they've ever been. Fuel prices are actually in real terms higher. People's rents, people's mortgage payments are higher than they've ever been, and that's going to get worse. Sorry to be gloomy here, going into next year, not easier for an awful lot of our population. So I think this work becomes more important than ever against that context, unfortunately. The question, I should probably know the answer to this, but in priority 1, that you've explained the work around the kind of high-risk groups, which I think is identifying kind of groups as opposed to kind of individual or sort of household or family kind of level. And then also the suicide prevention training, which references working with primary care, general practices, pharmacy, dentistry, and so on. Is it possible, have we ever tried, has anyone else ever tried, to go the step beyond the kind of population groups into identifying high-risk individuals or households? From a health perspective, we're increasingly trying to figure out who's at greatest risk of particular conditions or particular harm or illness, and what can we do to try and risk stratify and identify those people, so that people like RAF down the end here in GP practices are able to actually look in a more proactive way at what we might be able to do to support individuals. And the link to the training bit for me is, I'm guessing that, you know, fire or police responding to incidents or in people's homes may well be in and around environments where you've got those kind of complex lives and some of those other pressures that might lead people into some of this kind of place. So I just wonder whether there's anyone that's kind of nationally, internationally done work on trying to go that step beyond population groups to actually a more risk stratification approach that would then almost red flag appropriately in terms of information governance for other agencies who might be responding into people's homes or into situations.
Thank you, Toby. I think I'll let you come back in, Andale, because if I get 2 more people to speak, you'll forget all of the things that they've just asked. So I'll come back to you, and then Rochelle and David, I'll come over to you.
Yeah, no, that's fine. First of all, thank you very much. I think we'll definitely link in with all the links here just to see how we can be supported around the data and the data collection as well. And as Jane has suggested, I think a resource place online that we can get all those resources would really be helpful, so everyone can link into those as well. Thank you very much. With the priority groups, they were all very much data linked, or data, like it all came from the data in terms of like our local suicide prevention strategy, as well as from the groups that we went to and spoke to around that time. But I completely understand what you're saying, and we'll definitely look into expanding that and looking at different areas and how they can be specifically like supported in their areas as well. That makes sense. Thank you very much.
Thanks. We've got Rochelle and then David, and then I'll come to you, Ali.
Thanks. More of a kind of like an offer, I guess, of potential support, but in terms from looking at it from a children's perspective, when you talk about self-harm and the tools and resources that you've passed out to education settings and things, it strikes me that there's probably an alignment that we could explore with the safeguarding partnership, which obviously is everybody in the room, but we have a training portal that delivers training to all practitioners around anything to do with safeguarding. So some of those things actually might be best, you know, kind of routed through that mechanism as well as then the online website where tools and resources are there for partners to download and actively use and stuff. So there might be something there that we could look to help share that information across that partnership, which would be really fantastic.
Thanks, Rochelle. David.
Thank you. I think it's really great. It's really comprehensive, isn't it? And yeah, wide-spanning. Just a few comments that I hope you'll accept as improvements. It would be good just to know our kind of working denominator. So we should know our suicide rate per 100,000. So if we're going to measure success against the action plan, a decrease in that would obviously be a key metric. The other bit I think that would kind of help is just having a bit of a reference to some of the action plans and the associated kind of evidence that's driving them, if available, particularly thinking about the campaign against living miserably. You know, there's quite a lot of kind of national programs that are doing really interesting stuff in suicide prevention more generally. And then just on the current research, interruption would seem to be the primary kind of most efficacious kind of thing for somebody who's expressing suicidality. That requires people to have empathy and to be listening and to be aware of what's happening, and then give time to say, look, I'm really worried about you. You know, don't leave the office now. Just stay and let's have a conversation. So that interruption is really important. And that's not an NHFT or the mental health provider kind of role. That's an all of us role. Everyone who works in services or is in a public service role has a responsibility, and indeed the wider community do. So I guess on that point, it's just trying to think about if the campaign against living miserably have done a fantastic marketing campaign nationally around how to support people living miserably, what is our version of that campaign for Northamptonshire to help people think about that? What messages would we want to convey that make people think about interrupting, you know, pausing, thinking, being empathetic, providing hope, all of those kind of softer things. I think those are really important, and they're in here, they're just not clear enough to make me think we've got a comms plan. And that would really enrich this, I think.
Thank you, David, Ali, and then Jo.
Thank you. I suppose this is an offer of connection. So the place work and the local area partnerships, they're also focusing on youth and mental health and wellbeing, and it links back to what you've just been describing. And picking up on Toby's point, those local area partnerships now have profiles which do take you down to individual people. When you layer the crime profiles around the laps with health and wellbeing, mental health and crime as well, which can link obviously back to what you're describing around suicide prevention. So I think we could probably work closer at looking at maybe where we cut the data in a different way and home in on different laps as well. So which goes back to, and that's the whole point, isn't it, of place and bringing it right down so it's not one size fits all. And I think we must always remember that that's still an evolving model, but we can connect some of the work. So it's an offer for me to connect it.
Yeah, that's really great, Ali, really helpful. Jo?
Yeah, also linking in with that, just to say I think it's brilliant what you're doing, but from a voluntary sector point of view, there's quite often that is the first place people go to when they're feeling suicidal. So if there's a way that we could link the voluntary sector into that resource or into that training, I think it would be really good to add to as well.
Yeah, thanks. Adelaide, Jane.
Just a final response actually to a few comments. I think that the actual suicide plan for the area will have the suicide rate within it. I just want to really go back to your point, Toby, that we need to be really mindful that we may not see a reduction in that. What we don't know is what would have happened if we didn't do anything, of course, but because of the pressures that we know are associated with suicide risk, we need to be really mindful that may plateau or may go down. Also small numbers, random variation, etc. But we just need to be a little bit cautious about that particular metric. What I'd be also really interested in is self-harm, because self-harm and people who've been in inpatient psychiatric care, they're the single two biggest risk factors, in terms of risk of suicidality. So we need to think about that, I think, in terms of really keeping an eye on self-harm rates, because that is such a big indicator for us. But I get your point, Andley, that we need to look and dig underneath that data first. So yeah, just a point of caution about metrics there. The other thing, Toby, going back to your point, it is absolutely possible to take almost a population health management approach. We do know there's been very well established areas where we know the risks are much higher. So we know the risk of, for example, if somebody has been in an inpatient setting, what their risk is of when they're coming out of that setting. So we can take a more targeted approach to that. I guess what we have to be really clear on, though, is what interventions really work. Because with suicide prevention, lots of different things can work for lots of different people. But I do take your point that we could use that data in that sort of way.
Thank you, everybody. Andile, did you want to come back with any final comments?
Yeah, just a comment on the interruptions. I think that's a really important point. One of the areas we're actually looking at is locations of concern. And we've actually have our data analysts sort of looking at the data that we have and sort of plotting locations of concern across North Northants and West Northants, just so we can talk to the people that own those buildings, if it's government, if it's someone else that owns the building, just to say, this is a location of concern, what do you have in place, how can we support you, what else can we put in place? And then also just looking at places around there, corner shops, hairdressers, places around there that someone might pass on the way to that location, to see if we can implement maybe protect cards and have them on the training framework as well, because those might be the last people that see the person before something tragic happens. So just sort of making sure that they're supported as well. Yeah.
Thanks so much, Andile. I think this has been a great piece of work, and I think this has been a really valuable conversation around the table. So, Board, you're asked to note the contents of the review. I think I can safely say that you've done that, and there's been quite a lot to come out of that. So that's really useful. So thanks so much, Andile. And we move on to the emerging adult social care strategy, and Ali and Sam are going to present this paper. Thank you.
Thank you, Councillor Harrison. So I think probably a bit of a health warning. I don't intend to go through all the presentations because there's a lot of information. So you've got a narrative paper, and I'm just going to bring some headlines through. You've got 4 appendices linked to the paper. This is very much an emerging document. There is an ask of everybody at the Health and Wellbeing Board today to take the draft version of this strategy back into your organisations for comments, contributions and development. It's been co-produced with the adult social care workforce within NNC so far over the past 4 to 5 months. It links, Appendix A shows the links back to local area partnerships in a new sense of place. You have an exec summary draft. You have the full draft in Appendix D, and I'm actually going to bring the person journeys onto the screen to show you what we're actually trying to solve with the strategy. So the strategy links back all the way to the statutory requirements for adult social care. It is a framework with a 5-year direction of travel. And this, again, is a bit like the Health and Wellbeing Board strategy discussion. This is not going to be a document that sits on a shelf. This is about a change in the way of working. It's a cultural shift. And we all know that we're all under pressure. And if we don't do that, then, we're not going to improve the social care element for our population. So it is an outline. There's an outline case for change in the full deck, and it describes the problem that we're trying to solve, and I'll bring the person journeys up in a second. The essence of the strategy is that currently we don't put the person at the centre of how we deliver care. The person is moving between multiple services and does not have a strengths-based approach within that in terms of what the person can do rather than what the person can't do. So we have an opportunity to do something different. So that's just the headlines of the paper. So if I may, and then I'm happy to take some questions. I'm just going to share my screen. So if you look onto the big screen, here we go. So when you, in your Appendix D, when you look at these person journeys, so this is the first person journey, and I'm just trying to, it's not moving, is it? So let me go down here. Yeah, I'm trying to get my full screen with my mouse. Here we go. There. No, it's on my laptop. Here we go. I am. Oh, thank you. Yeah, thank you. My mouse and my arrow don't seem to be. No. Anyway, I was going to show you. If you go, for those on your laptop, if you go into the. No, it's not working, is it? If you go into full screen on your appendix in the paper, it shows the complexity. This worked, Sam, didn't it, on Friday, bizarrely, but. Let me try again, because I don't think you'll get the. Here we go. Just try this. Here we go. Okay. So what you can see is, for a person, the person in yellow coming out of hospital through our community teams, these are the adult social care NNC services. And you can see the complexity of the services. So the person moves between community teams, brokerage, finance, payments. And when you have a safeguarding concern, the person comes in and you can start to see how they go through multiple services. And if I go back to our complex, here we go. If I go up to a simple scenario, so a person coming out of hospital will then go to our hospital team in NNC, go to the reablement team and be reabled. In a complex scenario, the person will come through and they might go to the community hubs and the community teams, then they move to an inclusion team, then they move to a financial assessment. I think you can probably get the flavour of what happens within adult social care. And the staff have produced these person journeys, and you can see that there's a lot of duplication, a lot of handoffs, and this is just within adult social care, let alone when adult social care workforce is working with other partners. So what we're trying to correct, and in the case for change for the strategy, is a different model, which is place-based. And the model that you have in the papers is brokered around our 4 areas: Corby, Kettering, Wellingborough, East Northants. And the model is proposing that we put the person at the centre of that and have a strengths-based approach on it. And I felt it was important that we showed this appendices, because it's really difficult. There are a lot of problems around increasing demand, as there is a lot of our services. And that demand is not only coming from communities, but it's coming. We've got a high police referral demand. We've got the EMAS demand. We've got the hospital demand. It's the demand that's been generated within safeguarding, within adult social care. And in the current climate, if we continue that model of care, it's not sustainable. The finances are not there. It's not efficient in terms of patient flow through the system and how we work together. The commissioning and contracting teams within NNC and adult social care also feel that they don't have a person-centred approach on this. There isn't a place-based commissioning approach. They'd like to do more integrated commissioning to make sure we've got value for money. So there is a recognition from NNC adult social care workforce that we've got some good things, but there is a lot that also needs to change. And the essence of the strategy and what's emerged is through conversations with the public, from complaints and what the workforce are telling us. And I suppose, again, just to reiterate, the ask is that we would really appreciate further conversations with your organisations and how we develop this, so we don't do it in isolation and we make sure we're putting the people at the heart of it.
Thanks, Ali. And I think the sort of further complication about adult social care is that until you require it, you know nothing about adult social care. Generally speaking, you know, we're all pretty familiar with our NHS, even though that can be complex. But with adult social care, it's something that until you need it, you really have no idea about how it works. And then when you look at a chart like that, you can understand why people can get lost in the system, or feel like they've not been communicated well because they don't know what's going on. So improving that is, you know, it's clearly very important. I don't think, and it's really important for the people that are accessing those services, but it's also really important for our staff who are delivering that care, because when things are going wrong, it's really hard for them as well, and they want to deliver really good care, and they do deliver really good care, but we want it to be much more seamless and much more person-centred. I don't know, Sam, if you'd like to come in at this point and talk about it from sort of your perspective.
Yeah, so obviously the work that Ali's been doing with the teams is really welcomed. And obviously anybody who's close to the work that we undertake in adults, there's several portfolios. So the bit that you always hear me talk about regularly is I have the front-facing adult social care services, but I think what's really interesting about that is there's the back office functions within adult social care that you wouldn't necessarily even know were there. But for our people, so as somebody going through that, it's really complex. So we've been on a bit of a journey within adults, so my portfolio, frontline social workers and staff, around how do we really embed what we call the 3 conversations approach, but strength-based, and work with people, and you'll hear me talk about it in a minute when we go through the BCF, but to keep people weller for longer, link them to their communities, look at their strengths and not their weaknesses. And that's hard and it's challenging, and we've been on that transformation journey within my portfolio for probably at least three years, but it's really informed that actually it's okay if you have a conversation with somebody, the first person you approach, and they say, hey, do you know what, not what can't you do, what service can I give you, but what is it that you want to achieve? That's a really different way of managing people and meeting their outcomes, but also managing our demand. But actually, if the rest of our organisation, so if our commissioners and our brokerage officers don't speak the same language and don't have the same concept around the outcomes that we get for people, we lose that strength of message. So we work really hard with somebody to say, what is it that you want? And they say, well, I'm isolated and I want to have a sense of purpose. And we say, that's great, we're really going to do this. And then somebody says, but we can give you something. We can provide you with a service that's going to make that better. And actually, I think that's that whole marked shift around saying, no, you don't need us to do that. You might just need us to connect you to your outcome. And it really fits nicely with the place agenda. So we've been working on a place footprint since Vesting Day. And we've realised there's still some efficiencies to be made, so we still have handoffs within our own services. But this really is going to enable us to have a framework to drive that forward on a place basis. So if you live in Corby, looking at what are the assets and strengths within your local communities, your networks, the third and voluntary sector, what might be happening within some of those local groups that are going to keep you well. And so really this is just having that framework to drive it all forward. So what we're not saying is, actually it's all chaos and look what we do to people. What we're saying is we've got some pockets of really good opportunities, and now we've got a framework in which we can improve the whole of adults to drive that forward. So yeah, it's been really helpful.
Thank you, Sam. That's really helpful. David.
Thanks. I think I understand this now. It took a bit of contribution. So these are a set of internal processes. You're adopting the 3 conversations model to try and streamline a kind of a needs-based approach. And the ask of partners is that we kind of lean into that kind of co-identification of needs and look at assets and strengths to kind of encourage independence, so on. Just on the language bit, I think that would be helpful just to clarify. You talked about integrated commissioning to deliver a kind of better value, Ali, which I think is important, but there is a bit about better outcomes through that process of integrated commissioning. So I just want to make sure we don't unwittingly drift too far from the integrated care philosophy, because I think that's really core to what we're trying to do as a system and as partners. And also, I think one of the things that I'd really welcome us doing together is encouraging a team approach so that we kind of don't get into provider X, provider Y, you know, local authority, you know, North, local authority West. Like we're just a public sector team, and that kind of leadership, I think, will bring us to a place that would be really fruitful, I think, for our populations if we talk about teams and encouraging people to work together and take ownership of issues as a team and so on and so forth, because otherwise it just comes back into, just wrestles back into organisational silos.
Can I just come back in on that, and maybe we didn't articulate that very well. So the commissioning point's really important. So this isn't necessary. So it is about enabling our commissioners to focus in an outcomes-based way. So not the traditional time and task, not allocated hours, but actually, but stretching that even further, the ambition to be able to work almost on a micro-commissioning level, so it doesn't have to be us as a local authority or us as a system. Actually, if there's a derived need that's been identified, that we've got the ability to build that within that community and that vision. So absolutely, yes. And the strengths-based, so we do strength-based, and we do it well, and I have to say that because my team's worked really hard to do that, but we don't do that as a whole. And actually, my aspiration, and I'm sure Alice and the teams would be, it would be really great that as a whole place that we speak that language, that we have that culture of actually looking at the person, looking at their assets, looking at what we can do on that level to enable outcomes and not services.
Thanks. And Ali wants to come in as well.
So you're right on all those points, and there is a lot of information in the paper, but embedded in that is the emergence of an outcomes framework for this, which is absolutely where we need to go. The point around teams, and I suppose I want to emphasise this point, we've kept it internal within adult social care currently because there are many teams even on that screen. So what we've tried to do is make sure they feel as one team moving forward within NNC Adult Social Care, which then gives us a platform to create what you've just described with the teams and the organisation. So we've had to go internal, and actually, Sam, it's been quite difficult even to articulate this. You know, what is really happening now, and how do we describe, you know, do we want to change this? So, and again, just emphasising this has come from the staff, and that's a great platform then to move forward with that one team approach, I think. You know, and I haven't gone through the vision and the aims and all, you know, it's there and that's still emerging, but I think, you know, it's a commitment to do something different on a person strengths-based approach.
Thanks, Ali. I think that looks like everybody. So what we're asking is for the board to obviously note the development of the draft adult social North Ants. Oh, sorry. Yes, please, Steve.
I'm absolutely comfortable with sharing this with university staff, particularly I think in Faculty of Health Education Society, University Management Team. What would be really helpful though is for you to perhaps provide one or two critical questions that would get them thinking, because this is going to be quite, in a sense, alien to them in terms of their everyday work. So whilst they're all working in the health agenda, this is several steps away from their normal working day. I think to provide perhaps some critical questions around how you would like them to engage in the strategy would be really helpful, because in your recommendations it says ask to share and you know, to work to develop the strategy further. I think that's actually quite a big ask for an academic to be able to do that on first glance. So some guidance on one or two critical questions would be really useful. Thank you.
Thank you. And so that's really useful. And you've cut to obviously what it is we're being asked to do. Not only note this paper, but also to take this into our organisations and to help develop this strategy further. So I think there's a consent around the table that we've had a look at the strategy, and you know, it's really, you've got it now. hopefully you can take it away and have a look at it and think about it and see what as organisations you can do to help us develop this so that it's a strategy that works across the whole system. So thank you for that. We're now going to move on to the Northamptonshire Safeguarding Children's Partnership annual report, and I think, Rochelle, you're going to take us through that.
Thank you, Councillor Harrison. So this is the annual report for 22-23, and this kind of marks a point on its ratification and approval journey as it heads to executive later this month. So the annual report has been developed by partners across the whole of Northamptonshire, which may make up the Safeguarding Children's Partnership, and has been approved by the individual partners that sit on that group. The report sets out the journey that the partnership has been on in terms of there's been a redesign to its structure, as well as sets out the 3 key priorities that the partnership have been focusing on, which is taking positive action early enough, strengthening our response to exploitation, and effectively supporting our workforce and staff. The structure of the partnership has been amended slightly over the last year, and that's reflected in the report, but ultimately it is made up of a strategic assurance board, which is made up of chief executives, chief constable and elected members, and then the strategic leads group, and the agendas have been refocused to align with the prioritisation and make sure they're consistent. And then under that there's a number of subgroups, and they have working group structures that carry out specific pieces of work, and one of the new subgroups that was added was the neglect subgroup. So you'll see from the report, it looks a little bit different from previous years, and the approach that has been taken is to try and capture evidence of impact using specific case studies throughout, to be able to give examples of where progression and improvement has been made, and also the state of play within the safeguarding arena. We continue to support and expand the knowledge and skills of our workforce and staff, as well as wider practitioners, so beyond the kind of public sector arena, with appropriate training, as I referred to earlier on, which is online, and also increasing now post-pandemic with face-to-face training offers available. As we head into this financial year, the 23-24, the partnership continuing to strengthen and improve arrangements, and this includes things around having an additional focus on the education sector. So we're encouraging the involvement of an education representation within the strategic leads group, which has been really, really positive. Looking to embed the learning from reviews with a comprehensive process of impact of evaluation, which is really obviously embedding really good learning across the partnership, especially when it comes to things like CSPRs, which are published, and directly hearing from children and young people's voices to support aspects of that work, and that's something that is being really focusing and encouraged, which really marries really well with the co-production focus that we are really plowing ahead with in children's services. So I'll leave it there, Chair, but happy to obviously pick up any questions. Not that I might not be able to answer them, but I will obviously do my best.
Thank you, Rochelle. It's a really good report. There's a lot of detail there, and I just wanted to say I really like the case studies in there. I think it brings it to life, which is really useful for, helping us to really understand the impact of some of this work. So that was really great to see. Does anybody have any comments or feedbacks for Rochelle? Thanks, Toby.
Yeah, thank you. As someone who personally and my organisation obviously is kind of embedded throughout all of the structures that are set out here, kind of recognise the work. I think this feels in far better shape than it has for a long time across our county. I think as a result of a lot of different organisational efforts into this. That doesn't take away from the fact that this continues to be one of the kind of most harrowing areas of work that lots of us kind of get involved with, and the cases and things that come through are genuinely traumatic. But I think the work and the response and the approach that is there feels in a better place than it has for a long time. Particularly wanted to kind of commend the chair's work in this space, because I think she's helped to bring together and manages that not easy thing round here of holding an independent space amongst a whole number of other agencies and being able to do that in a supportive way, but also in a way that applies appropriate challenge into those conversations as well. So commend the work to this board as someone who's heavily involved in it, and I know we'll see it as it goes through its journey into other routes as well. Thank you.
Thank you, Toby. Okay, lovely. Well, we're asked to note the contents of the report. I think we have done that, and thank you so much, Rochelle, for presenting that to us today. If we can move on then to the North Northamptonshire Place Development, and I think that's going to be you again, Ali?
Mm-hmm. Thank you, Chair. So as we have in every Health and Wellbeing Board, this is an overview of where we've got to with the place development. So what you have in your paper and narrative are the recent second round of emerging priorities for the local area partnerships. And if you look at those priorities coming through, they mirror some of the conversations we've been having this afternoon around priorities as well, particularly around the economic element and concerns and preparation for winter. So the slide deck gives you more overview of that, and just as a reminder that we maintain and we're continuing to focus on community transport and engagement with the youth and their health and wellbeing. So the previous priorities are still very active through the multi-agency task and finish groups. Engagement is still really good, significant number of partners attending all the lab meetings and the multi-agency task and finish groups. It's probably fair to say that we are looking at the function of those and the discipline around focus on delivery and the approach in those meetings to make sure that we are making a change and that we're making a difference within that. And we're doing a big exercise currently with partners just to grasp what that means, to make sure we've got some visibility of it. The second half of the paper reflects back a developmental session that we had a few weeks back for the North Place Board to look at its function, how it moves forward, how it has an oversight and a grasp of the emerging development and maturity of place. And public health colleagues have designed, on the back of NHS Scotland, a maturity matrix which was explored within that workshop, and you can see the output in the paper. And it starts to give you a bit of a flavour of the important components and indicators of what a mature place looks like. So it's how we make sure we are doing as well as having an oversight. The Place Board recognise that they need to set the culture in terms of collaboration, and they also recognise that they've got responsibility to try and join up some of these strategies that are connecting and trying to think through how that would enable place. So the paper just gives you an overview of where we've got to with the development, and I'm happy to take any questions, Chair.
Thank you, Ali. Does anybody have any questions for Ali? Sheila.
Yeah, we had an East Northants North Flat meeting last week, a working group meeting, and we were talking about all the services that were available in the community, and the official ones that most people knew about and often couldn't access quickly. But there's a lot of support in the community that people who need it don't really know about. So we were talking about how we could get the message out to everybody. We did some asset mapping in our area, you know, and looked at each other and said, well, I didn't know that was there, you know. Not that we particularly needed it at the moment, but it was something that ought to be generally known. So I think our conclusion was parish councils, if possible, to get messages through every door. GP surgeries, and I do use our PPG notice board for everything that I can get my hands on. But also these free publications that go through the door. We have one in Thrapston that goes through every door, and I'm sure there are others around the county that go too. And it would go a long way if people knew that help was available as a prevention rather than going to help them when they really need it because they're not well.
So every lab is having the same conversation. It's a common problem, and the whole essence of that of the labs is prevention and sharing information. The the assets you've just described, there's going to be a launch of the lab asset maps in the next 2 weeks. So there will be a tool for stakeholders and not the public currently, but it will go into the public domain in the new year. So that will be launched. That's a product that's come out of the labs. There's no right or wrong way, Sheila, to do this in terms of, the more we share information, but that networking and that discussion that's going on in the labs is creating all of that as well. We're working closely with the GPs in the North to make sure that we understand what they need, and obviously the social prescribers. So we're just continuing to work on that as a priority. But if we can crack that, and also then make sure that we've got the right public knowledge around that, then it will really add to prevention, because we've got so many assets, we're tripping over them at the moment, aren't we?
Yeah, thank you.
Yeah, I mean, I couldn't agree more. You're absolutely right. It's a discussion that's come up in pretty much every lab, and it's not always as easy as it sounds to solve, because people don't know they need something until they need it, so they're not looking for it until they need it, and they're maybe not looking for it soon enough, and things have escalated by the time, and so then they're needing some of the more interventionist services. But prevention is absolutely everything, isn't it? If we can crack the prevention nut, we'll make a massive difference across the board. So, one of the most powerful things, of course, is word of mouth. And the more people know about things, the more they talk to their neighbours, the more they talk to their friends and so on, the more likely people are to know what's out there. But we've got to make those first steps, haven't we, Sheila? And I think you're absolutely right that any method we can use to highlight the different things that people can access that aren't necessarily, sort of the official services, as it were, is really, really important. Both David and Rochelle, you seem to come as a pair each time. You're both inspired at the same time. Rochelle, get over to you.
Thank you. It was just to come in on that comment actually about sharing information, and just to say that I was lucky enough to have a sneak peek of the asset mapping work, and just to say, Ali, the work that Hazel and Becky Hart and the team have done on it is phenomenal, and I think it will be a great asset for the wider stakeholders and partnership to kind of be able to use appropriately. I do think there's something worth recognising in North Northamptonshire, though, in the fact that we aren't where we would want to be in terms of information sharing, and there is a lot out there in the community that we don't know about and people don't know. And I think that hearing that feedback from the labs just reinforces the fact that where we aren't yet where we want to be, and whether the kind of area and angle that I'm thinking specifically is around family information service. So obviously as a local authority, we have a statutory obligation to around our information, advice and guidance with family information, to be providing information on activities, services, what's out in the community and things like that. And it's not where it needs to be. However, as part of the Family Hubs programme of activity and working really closely with with Hazel and the team, we're looking to improve that through a digital front door. So it won't, so there'll be a digital front door, but obviously then more kind of physical, actual information and targeted comms through connectors and things like that, and also using things like GP practices and stuff like that. But to be able to actually resolve it by having that foundation, which we should have, which is a really robust family information service and local offer, and then working with the labs, I think we will in time be able to start really shifting that and making it a lot more of an improved and joined up offer in terms of being able to share information about activities and groups and things that are on people's doorstep, that they don't know about.
Thanks, Rochelle. David.
Thanks. It's a great point, Sheila, and I agree with all the comments made. And the paper's brilliant. It's fab to see all that kind of feedback from residents about things that matter to them, which is great. Just an offer, I guess. I mean, we've got a Foundation Trust office which has a membership. There are people working in that office communicating things that we do. There's similar in KGH for sure. And I guess that directory of service, I think that we're kind of describing, or a localized kind of directory, which kind of could be mapped to the kind of the geographies that we've outlined here, kind of, there's a universal offer. And that would quite help the NHS, I think, in a way, because we would be explaining, you know, as a demand management type approach, you know, these are the other things that are available that are not hospital-based and are actually closer to you, and you can access through your GP or online, etc. So I think there would be real benefit in us doing that. And I wonder if, well, an offer, I'll leave it with you, Ali, to decide whether to take it forward, is we could bring those teams together and say, look, we want to try and map this and come up with something that's universal and localised, and we want to kind of use some of the resources in partners to help do that. I think we'd be able to support that and use our membership base as an FT to drive some of that as well.
Thank you, David. I'll take you up, and I think we're beginning to tap into some of that. Comms leads are all coming together over this as well. And when you see the launch of the LAP maps, it won't just be the community offer, it will be statutory services, it's schools, GP, it's a broader element to that, and spaces as well, so we can build on that. So I think it's, I think if we all own it, which I think is Rochelle's point, isn't it really, it creates the right foundation. So yeah, I'll come back to you. Yeah. Yes. Exactly. Where do you live? Where are you going when you're discharged from hospital? What's out there? Exactly. Yes. And the other element of this, it connects back to the adult social care strategy. There's a clarity, really, that we don't use and understand that offer out there to reduce demand, and also to try and filter that part of that model is that information for members of the public around alternatives, so everything starts to tie together.
Thank you. We've got Jane and then Trevor.
Two comments, really. One is, I think the LAPs, all of the priorities that are coming out of the LAPs fit really well with the health and wellbeing strategy priorities that we're proposing, which is really great. Few, but no, it's really great. So that's something that's going to be really helpful, I think, in terms of taking that work forward. The other thing that I think where we've got a real opportunity with the LAPs, and I'm talking about our services from a public health perspective, but I'm sure lots of other partners will feel the same around the room, is that when we've got addiction services and smoking and things like coming up as issues, this is where our opportunity is to work with those communities and say, okay, for addiction services, for example, or drug and alcohol services, what is it that, you know, why is this a concern? What else could we be doing? How else we work with your communities to engage people who perhaps have not been engaged so far? So particularly alcohol services, for example, lots of people who need alcohol services don't engage. So I think this is where I see the LAPs taking us as well in terms of an operational delivery vehicle. I don't know if you've got any thoughts on that one, Ali.
So I think what you're describing is the wiring of what's coming from the communities all the way through to statutory services and strategies, isn't it really, I think? What I would say, they could well be delivery vehicles for the future. They are in various degrees of maturity at the moment. And my point, probably my subtle point, that we're looking at the function to make sure they're focused on delivery, and we're making sure that we have an approach around that. Once we get to that, which we're not far off, I think, at the front end of next year, then, and we could certainly be testing that out, but they've got to start to show the change. And then, rather than us all then putting the extra pressure on them, saying, right, there are delivery vehicles, but in essence, through place, that's how you bring that population health management approach, and then the individual elements that we talked about before, isn't it? Because you're cutting your population in a slightly different way. But yes, there's an opportunity.
Trevor?
Yes, thank you. And just reinforcing the point, please, we want to engage around this with our membership, but particularly our governors, because they are also a major source of information about what's being provided locally, because part and parcel of what they do becoming governors is make a lot of those links. The other point is, and I don't know what the NHFT number is, but in Northants we've got approximately 5,000 staff living in Northants. So how do we use those as assets in these conversations as well? And I know if you look down at somewhere like Frimley Health, every member of the local authority and health service locally are considered as an asset in this conversation across East Berks and Northwest Surrey. So I think it's how do we use our own staff in some of these conversations as well.
Thanks. And Toby.
Yeah, just a really quick comment, Chair, mindful of time, but on the conversation about who's got the best information on what services that are non-medicalised are available in different local areas, the social prescribing teams, I kind of tend to think, and Spring Service have been building this kind of database. I'm sure you're connected with them anyway, but that's kind of, if I was thinking who can I picture that's got the best handle in local areas, it's probably kind of some of that team, as well as potentially some of the things like the Directory of Services that we still run that sits behind NHS 111. I know that tends to lean a bit more towards the medical end of things, but there's stuff captured in there that probably isn't as visible to David, your teams, or Trevor, the staff of the 2 hospitals, etc., but can be directly accessed without needing referral through from a healthcare professional.
I'm happy to come back. If I take Toby's point first, so absolutely social subscribers are connected into everything, but it's interesting, when you put everybody in the room, they still don't know everything. So it's, and every organisation's got a website of some sort that's got information on it. So the essence of this is how you bring it together at a place level, using the existing directories. And also the key thing is how you keep it updated. And there's got to be, and that's been part of the problem with many tools, I think. So absolutely, and also it's not just the signposting, it's the availability and the hours of the services. And Trevor, to your point around governors, this just reminded me that at the very early days of the North Place development, I came to a governors meeting between NHFT and KGH, so I think it's probably time to go back with all of this now, because we said we would do, we're now doing. So I think absolutely it's a trigger for me today to do that again.
Know your patient, know your place.
Yes.
And that's an expectation that we would be asking our staff to kind of buy into. So they need to know their patient, and they need to know the place that their patient comes from to be able to support them back to independent living.
Yes.
And that'll be equally as applicable to Trevor's teams as to you know, a mental health community trust.
It's a different way of thinking, isn't it? Yeah.
It's a different way of thinking. Sorry, Chair. You know, one of the problems is people see the hospital as a sort of an edifice, and ignore the fact that we have to work out in the community. It's not just the community midwives that are out there, and it's not just NHFT. We've got to have those constant links back into the community and know what's available, and sort of help to inform that discussion as well.
And then picking up on your final point about how we do this and the workforce element. So the place board, which we're meeting at 4 o'clock today, so we've got all of the executives across all organisations. That's the engine room behind this, to be able to take things back into organisations and use all the tools and everything that we're producing, really. So, so thank you for those comments.
Thanks, Ali. Steve.
So as you mentioned, place board, I'm looking at the radar diagram, and I love a diagram, but I don't really understand it. And I suppose you had to have been there to have got it. But am I right in thinking that the relative position around that matrix is where you believe the maturity of the board should be at any particular given point in time over the next 2 years?
So it's work in progress. So it's just a little bit of an insight into it at the moment. So it shows that we need to define those indicators. What are the key indicators on those, the radars, effectively, where we're at now, and then where we need to be. So it's that constant check back, but it isn't just the place board. That needs to then filter through to the LAPS as well. So the LAPS would obviously at a local level should also be able to use the same tool but to refine it. And I think there's a point in there around communities engagement. So that's going to be at a different level between all the different LAPS as well. So I think it's evolving. And I think it's quite subjective at the moment, but it has been proven that tool, or a much more complicated tool than that in Scotland, to show a bit of a grip, because I would expect as a health and wellbeing board that, you know, as you fast track 6 to 12 months ahead, is are we maturing in place or not? Are we moving in the direction, not just what we were saying about LAPS? The board recognises that it's not just about the LAPS, there's more we could be doing to set that direction of travel, connect back into organisations, some of the conversations we're having today, and really grasp place.
Okay. And presumably there's a definition, if you like, of what 0 to 7 means, which I can't find, but clearly would give an indication as to the strength, if you like, or the pace of development against any particular criteria, and what you're making that judgment against. I found it quite fascinating. I'd like to know a little bit more about it. And having worked in Scotland, I think I know where you've got this from, but it's fascinating. Thank you.
So I'm happy to come and have a conversation
Yeah.
with you about it,
Yeah.
and a bit of a debate about whether we use numbers or not, but it's all about grasping maturity of place, I think. And we haven't defined all those criteria as yet. It was the start of a conversation.
Okay, thanks.
Thank you very much. Ali, unless I was stopped concentrating at a particular moment in time, I'm not sure that you mentioned the progress of Support North Northamptonshire.
I haven't, so I was going to move on to that.
Okay.
So, yes, and we haven't got Pratima, but we do have Joey here, who's chair of one of the CWFs and has been leading Support North Northants. So if you remember that voluntary sector social enterprise collaborative approach, which has been held by the Place Board, we have presented here several times on progress with it. So that the case for change for that model is pretty much where it needs to be, and we'll be starting to loop through that governance early January. It is difficult, and picking up on Toby's point about social prescribing, we've got lots of similar models emerging. We've got social prescribing for PCNs, we've got Support North Northamptonshire, we've got Ageing Well, we've got Spring social prescribing. All of these models are working in the same territory with different timelines and contracts. So Support North Northamptonshire is making sure that it is positioning itself and working with all those very similar service offers, and actually it's interesting when you put everybody in the room, they don't all know the service offers either. So I was chairing a North group this morning, bringing all of that together. So the point in the paper is signalling that case for change is emerging, and showing the value for money and the good work that Support North Northamptonshire has progressed in doing. It's not easy, Joe, I would say, but I don't know whether you want to add anything to that.
Okay, well, thank you. Does anybody have any questions on that? Fantastic. So we have noted the progress of the new sense of place, the emerging thinking from the delivery board's workshop, and the progress of Support North Northamptonshire. Is everybody happy that we have done that? I think so. Thank you very much. We're on to our final substantive piece of work, which is the Better Care Fund performance report. So I'm going to hand you to Sam.
Thank you, Chair. So I'll take the report as read. It's not particularly long, it's quite concise. Really, this is to provide you with a performance update on the Better Care Fund, which I'm sure many of you are well versed in me talking about that, but just to give you some context around that. So the Better Care Fund is critical in supporting people to live healthy, independent and dignified lives through the joining up of health, social care and housing, and wrapping those around the person. Two core objectives that the Better Care Fund sets out: to enable people to stay well, safe and independent at home for longer, and to provide people with the right care at the right place and at the right time. So during the last Health and Wellbeing Board, I provided a substantial pack of documents for board members. One of those was the planning template that looked at our Better Care Fund allocation and how we were going to use that against schemes to deliver the objectives of the Better Care Fund, and then the narrative plan which described the way that we were going to do that. So now we've had how we have got our spending set out, the metrics that applies to, that we have a duty to report on a quarterly basis, is the rate of avoidable admissions to hospitals, the volume of people discharged to their usual place of residence, the volume of people at unplanned admissions due to falls, permanent admissions into residential and nursing care, and the effectiveness of reablement. So the metrics, the data that I've provided is Q2. I'll just go through them one by one, and then I'm happy to take any questions in relation to those. So interestingly, the rate of avoidable admissions throughout the whole of last year, we weren't able to provide an update on a quarterly basis for those. So we have moved forward in our ability to be able to report. Broadly, we're on track to meet that metric at this point during the reporting process. I think we've heard lots about some of the community schemes that have been set up within our communities that are helping people to manage complex and long-term conditions within the community. We've got enhanced numbers of people going through our health remote monitoring schemes, including some people with COPD, and we believe that that is all contributing to the performance against that metric. The next metric is around people aged 65 and over who are discharged to their usual place of residence. So if somebody's been admitted from a residential or nursing home, that they return there, and if they've been admitted to their own home, that they return there. We're consistently good at achieving our rate in people returning to their usual place of residence. So we had a plan of about 94%, and we're coming in with an actual Q2 figure of 95.3%, which is really positive, and we anticipate that that will continue into Q3. The next metric is in relation to emergency admissions due to falls. Again, broadly on track to meet that target. A number of kind of key activities that have happened, not only within our rapid response services, but our reablement admission avoidance services. So we've rolled out razor chairs, so pieces of assistive technology, to our care homes, but also to our teams that work in the community. That means if somebody does have a fall, they're not necessarily, if it's non-injurious, they're not waiting for an ambulance conveyance to be lifted off the floor, so not being subjected to those long waits, and subsequently helping us to avoid people being unnecessarily conveyed to hospital where they run the risk of being admitted. The next rate is the admission. The rate of permanent admissions to residential and nursing home placements. And this metric had been a little bit of a muse to us. We'd always shown as a higher proportion, and yet our detailed metrics were showing that we felt that there were some abnormalities. We have uncovered those, and that we've now rectified the data, which actually shows that we are on a positive trajectory for our rates of admissions to residential and nursing care. So we had a rate in Q1 of 127 people, and this has risen to 246 in Q2, but that is lower than our estimated annual growth, which is really positive, particularly given the pressure that we're seeing. The last metric is the effectiveness of our reablement. So as you'll all be aware, we've invested in North Northamptonshire quite heavily, not only in our internal reablement team, but partnering with an external reablement partner, which actually has enabled us to take record numbers of people through what we call Pathway 1. And here we measure the effectiveness. So actually looking at those people who go through reablement, how effective are they, and are they still at home in what we call the 91-day indicator after discharge. So in Q1, we were well above our target, and we were outperforming ourselves. What we have seen is that that has slightly reduced into Q2, so we're at about 84%. What I would say is that's quite likely to be reflective of the level of acuity of person that we're seeing coming home. However, we do anticipate that that will jump back up during Q3. But I've said quite a lot there in a very short space of time, so I'll take any questions that anyone may have.
Thanks, Sam. Well, it's a really positive report, isn't it? Which is great to see. And I think, you know, against the backdrop of such a huge increase in demand across the system, I think that's, you know, it's even more positive than perhaps it would, you know, given the circumstances. I think it's an incredibly positive report. So thank you for that. I see, I think it was Toby had his hand up.
Yeah, thank you. A thank you and then an ask. The thank you bit, I'm always, when I see a paper that's got a number of sets of data, all of which seem to be pointing in the right direction, my first sceptical tendency is to ask my team whether that all looks right. And knowing some of my team in the ops team as you do, their comment was that North tend to be doing pretty well on their numbers at the moment. And bearing in mind some of the individuals, that counts as a compliment. So thank you. The ask bit, just looking ahead, some of you probably would have spotted this afternoon, the talks between the government and the BMA have broken down again on junior doctors. So we've just got 9 days worth of industrial action that have been announced. The 3 days running up to Christmas from the 20th to the 23rd, and the 6 days after New Year, from the 3rd to the 9th. Now, anyone who knows how the NHS and health and care works, in the run-up to Christmas, we have a massive push to empty hospital bed capacity to try and free up space to carry us through what is always a difficult period in terms of demand and other services not being in place. And in the days after New Year, we always have the reverse scenario, which is coming into everywhere absolutely full and doing everything we can to bring teams together. I mean, I won't make a political comment about the timing of all of that, but, you know, it's pretty clear, isn't it? So the arse bit is we're going to have to go again, aren't we, in terms of how we look and plan and think about the response across all of our organisations through that. Particularly mindful, actually, Trevor, that looking across our 2 acute hospitals in Northamptonshire, Kettering has consistently had the higher levels of absence from staff during industrial action days, very markedly so, actually significantly higher percentages of staff who could strike have done so and chosen to do so previously. So if that repeats itself, we'd expect that site to be our most challenged across the county. But hold on to the thank you.
Yeah, thanks for thoroughly depressing us, Toby. Trevor.
Oops, turn him on. I think just on the last 2 metrics there, on the nursing homes, and it links back to what Toby's just said, I can't look at that without thinking, is this also a factor of the availability of nursing homes? So if I can answer the second one, I know you're rushing to come in on there. I know, for one, the sheer volume of sort of reablement, and I think that the 4.10 effectiveness of reablement understates it. You said it, but shouldn't we have some hard numbers against this to actually show the number of reablement packages that are being delivered? Because when you say a percentage, it belies the underlying trends that are going on behind that.
Yeah, thank you. And it's always one of these things, so I'm going to be really honest, this isn't the most exciting report. And actually, I did, in a different forum, present some different data, showed the data in a different way, which more or less tells the story. And I'm more than happy to try and incorporate that story alongside the performance metric, if that would be helpful. So 2 things. The metric on admissions to residential and nursing placements is around our permanent admissions. Now, for as long as I can remember, or at least since 2018, we've adopted the discharge to assess process. And although that was mandated to us during the pandemic, we, particularly and in the north, have never stopped doing that. So we always think home first, which is why our numbers through reablement and Pathway 1 are so significant. And for those people that we can't get home first time round, and actually the people that we get home first time round, and I'm trying to remember my figures now, I think it was 79.9, no it wasn't, it was 89.9% of people that we get home first time. And I can provide them, or I can certainly bring them to the next board. But then we use the discharge to assess. So if we place somebody in a bed, we will give them, where possible, using places like Thackley, intensive reablement support, occupational therapy, and then we do our assessment and we try again to get people home. And of those people who went into a bed, we get about another 38% of those people home second try. So there is some challenges around capacity in relation to particularly nursing capacity, and nursing capacity for our most complex people. But that's not a driver for discharge, because actually the way that we've grown some of our Pathway 2 capacity and the work we're doing across the system shouldn't be impacting on that metric, particularly when we're looking at those people within an acute hospital that have no reason to reside and are looking for discharge. I absolutely think, yes, we should. So second question, absolutely, we should bring the figures back. So I think and again, I'm doing this from memory, so apologies if they're not absolutely accurate. So I think during the demand and capacity work, which was part of the BCF planning, we worked as a system, so collectively, to say how many Pathway 1, 2s and 3s did we have capacity? What did we forecast that we were going to see? And that's always quite a challenging thing to accurately forecast. So I think we'd forecast broadly about 630 Pathway 1 packages, because we'd invested in Pathway 1. But actually, when we recently went back and said, actually, against the capacity and the demand that we thought, what's the actuals told us, we were actually at something like 933. So we were seeing significantly that we were delivering over the anticipated capacity. And I'm not saying that's not the right thing to do, because particularly on Pathway 1 it is. But I think maybe that's what you as a board need to see. You need to see those actuals rather than just the metric that says, and, you know, people are at home 91 days after. It's almost the so what? So we also have, you know, information on, so we say we've re-abled people, we've made them more independent, but what does that mean? What does that look like? How many care hours have we reduced? Those types of things. So if that would be helpful, I can try and bring some of those highlights to the next board.
I think that'd be really useful. It brings it more to life, doesn't it? Gives a bit more context around the figures that we're being presented. David.
Thanks. It's really helpful just on the report, Sam, but just going back to Toby's point, and it might be, I don't know what we've done with the Outbreak Control Board, but weeks 51 to week 2 last year were the peak of flu and COVID. We've had an outbreak today, 6 patients, 5 staff. So married that with kind of junior doctors en masse being off kind of campus, potentially. Just a flag, it's probably worth us just keeping close on that, and whether we do need to think about a kind of a public health kind of intervention if needed, considering what we know about last year. Yeah,
thanks, David. That's really useful. So we're pretty much now at 1 minute. Well, we're 1 minute to 4. I know that Ali's got to get it, and I think Joe's got to go as well. Is that right, Joe? No. So it's just Ali's got to go. So I think that we have we've looked at the Better Care Fund performance. We've given that a good look over. So thank you for that. The final agenda item is just any other business. So look around the room and see if there's any other business forthcoming. It looks like there is not. So thank you very much, everybody. Another good health and wellbeing board, I think. And I look forward to seeing you at the next one. Thanks very much.